Hello, my name is Megan Cheslock. Today I'll be discussing a case of occult subarachnoid hemorrhage leading to cerebral salt wasting after a fall. The patient is a 76-year-old community-dwelling, functionally independent female with a history of paroxysmal atrial fibrillation, for which she is anticoagulated with warfarin. Additionally, the patient has a history of mitral regurgitation and chronic systolic and diastolic heart failure with a left ventricular ejection fraction of 40 to 45%. The patient initially presented to the hospital with a chief complaint of chest pain that had been persistent for 1 week. She was admitted to the hospital to rule out acute coronary syndrome. On hospital day 2, the chest pain did resolve. Serial EKG, serial troponin, and telemetry were unremarkable overnight. Unfortunately, during the evening on hospital day 2, the patient sustained a fall in her washroom and hit her head on the sink. At this time, the patient was incontinent of urine. Of note, there was no associated loss of consciousness, tongue biting, shaking, or focal neurologic deficits noted. The patient was urgently evaluated, and her vital signs were within normal limits. The patient did, however, appear confused and was disoriented to place, time, and situation, which is an abrupt change from her baseline of being fully oriented. Due to these concerning findings, an urgent CT scan without contrast to the brain was ordered and returned negative for any signs of acute intracranial bleed. In the center panel towards the right is a graphic of the patient's brief hospital stay. We did discuss hospital day 1 and hospital day 2. On hospital day 3, the patient had increasing confusion and started to complain of a headache. At this time, an MRI was ordered and was negative for acute stroke or bleed. Also of note, the patient's serum sodium did precipitously drop from before the fall, 140 millimoles per liter, down to 120 millimoles per liter after the fall. Additionally, the patient's labs showed signs of hemoconcentration as there was a rise in her hemoglobin from 12.2 to 14.8. Given the acute hyponatremia, serum osmolality in urine studies, including urine osmolality, sodium, chloride, and potassium, were ordered. Due to a need for more frequent monitoring of lab values, and given the patient's worsening functional status, she was transferred to the intensive care unit for evaluation of hypertonic saline administration. She was increasingly somnolent on hospital day 4, and due to our concerns for intracranial pathology, despite the negative imaging findings, a lumbar puncture was obtained. On the right panel, you can see an example of the findings we saw in the patient's CSF. Shown there is a light color CSF, characteristics of xanthochromia. This is in comparison to a traumatic lumbar puncture, in which you would expect serial vials to be more light in color. You can see the xanthochromia here is consistent throughout the 4 vials. Given the acute subarachnoid hemorrhage and the patient's precipitous drop in serum sodium, we did diagnose her with cerebral salt wasting. It can be difficult to differentiate cerebral salt wasting from syndrome of inappropriate antidiuretic hormone. However, there are certain biomarkers in clinical exam findings that can help to differentiate between the two. In the center panel in the lower left is a diagram showing some of these biomarker and clinical findings. We do believe the patient had cerebral salt wasting because she appeared hypovolemic with a low blood pressure and evidence of hemoconcentration on her labs. Additionally, the patient had low serum sodium, low serum osmolality at 267 milliosms, and elevated urine osmolality, which we can see is 619 milliosms. Also important in this diagnosis is the elevated urine sodium of 26. We would expect this to be much lower, as the patient should be holding on to all the sodium possible in an effort to raise the overall serum sodium. Finally, the diagnosis of cerebral salt wasting was supported by the patient's improvement with treatment with salt tablets and hypertonic saline. Given the acute subarachnoid hemorrhage, the patient's warfarin was discontinued, and over the course of several days, her serum sodium and mentation did improve.